So that brings me to the last part of the research, which is, what does this mean for patients? What have we discovered clinically? So, questions. Could infection or inflammation cause a stroke in patients who are at risk? Actually, we know the answer is yes. There was a big study done in people in their late 60s, and it showed that if they had quite a serious upper respiratory tract infection, lung infection, common of course, the chances of them getting a stroke or a heart attack within the next 3 weeks was 4 times greater than if they didn't have an infection. And that could be because they're increasing the levels of IL-1. Do inflammation and cytokines make patients worse after they've had a stroke? And of course, can blocking IL-1 be beneficial? And here is where those imaging techniques really do come into play, and I'll just give you 2 examples of them. This is 8 patients who've undergone a PET scan. The 4 on the bottom are elderly, but they have no risk factors for stroke. They're normal, they all have the same body weight, but these have things like elevated blood pressure, same age and so on. All of these 4 are at risk of a stroke because we know they have the risk factors. And what we're doing on this PET image is looking at the signal sent by a molecule that binds to the activated glia in the brain. So wherever you see colour, a little bit here, not very much, a lot up here, that means the glia are activated and probably producing IL-1. So we can actually look inside somebody's brain and say, are your cells activated? Then we can use the same technique to look after somebody's had a stroke. Here's a cartoon just showing where the stroke is, and you won't be able to see very well here, whether it's on this image, but it's here. But here again is where the activated microglia are. So just after a stroke, the patient's glia are activated and they're probably producing IL-1. But then we come to the more difficult questions to answer. For anything to be a useful treatment in stroke or brain injury or Alzheimer's, we have to know, does it actually get into the brain? The IL-1 blocker is quite a big molecule, and big molecules don't easily get into the brain. Secondly, is it safe? Well, it's probably safe because it's IL-1RA, it's called Kineret, as it's marketed, is used to treat rheumatism without any adverse effects. But that doesn't mean to say it'll be safe in stroke patients who have lots of other risk factors. They're much more poorly than patients who have rheumatism. And then I was going to say the $100,000 question, it's actually about a $100 million question to answer it, is does it work? To answer the question, does it get in the brain, we studied a different group of patients to stroke patients, and these are ones that have had a hemorrhage. There's just one gory picture in a minute. And this is an image of a brain of a patient who's had a subarachnoid hemorrhage, and these white things here on the scan are blood, and this is an angiogram, and this is what's called an aneurysm, this bulge here, and that sometimes bursts. You never know when you're going to get a subarachnoid hemorrhage. There are certain things that trigger it, alcohol and tobacco, but what happened in this patient is there was damage in this part of the brain, very similar to the sort of damage you get with a stroke, but rather than a blockage, it's a burst. Now, we treat these patients in two ways. One, either, this is the gory slide, either open up the brain and tie off the bleed, or more commonly, do it without opening up the brain and put a tiny, tiny thread through the body and up into the aneurysm to block it off. But what's important in these patients is that their brains swell, and therefore a real problem is the pressure inside the skull. So what the surgeons do is to drill a hole into the skull and drain off the fluid around the brain, the cerebrospinal fluid, in order to reduce the pressure. This is done routinely and works very well. But what it means is we can sample that fluid from inside those patients' brains. So what we did, after lots of ethical agreement and getting patients' agreement, is we took a group of patients who'd had a subarachnoid hemorrhage, we infused them with the IL-1 blocker, and we could measure if any of the blocker gets into the brain, into the cerebrospinal fluid, and it does. So this is a graph showing the levels after infusion in the blood, very high, and here the levels that get into the cerebrospinal fluid. And in units, this is picograms per mil. Believe me, that's a lot, you don't need much of this, and that's about 100,000. And that, we think, is enough to work. So we have undertaken a small study in stroke patients, mainly to see if it was safe and it worked. It's what's called a phase 2 study. When you do clinical trials, there are up to 4 phases. The first one is you give the drug to healthy volunteers to see if it's safe in them. Never at the same time, as was done at Northwick Park, which was absolutely unbelievable. You never give a new drug to more than one person at a time. Then a phase 2 is when you give it to the patient group you're looking at, who've got lots of other problems like stroke, and that's what we've done. A phase 3 is a really big study, several hundred patients, to see if it works. Phase 4 is normally when it's actually out in treatment, and you keep monitoring to see if there are any side effects. So, and this was double-blinded, placebo-controlled and randomised, and what that means is all of the people involved in the trial had no idea what anybody got. You call a centre 100 miles away and say, I've got a 75-year-old woman who's had a stroke 2 hours ago and it's this severity. And that centre not only chooses which vial we give them, but balances out the groups such that you don't get all women in one group and all men in the other, and you don't get all the severe strokes in one and in another. All done remotely. And so the patient would either get placebo or the IL-1 blocker, and we have no idea until it's completely finished what they got. The main thing we wanted to be sure of was that it was safe, and it was safe. But we did, of course, look 3 months later at how are the patients doing. Are they any better or not? And what we use is clinical ranking scales. Details don't matter. But there's one on the left that's called Bartel, and one on the right that's called Rankin. And that's the placebo, and that's the IL-1 blocker. Again, the placebo and the IL-1 blocker. And just to simplify it for you, the white blocks mean you're extremely well, and the black ones mean they were dead. So, first of all, frighteningly, nearly 30% of patients coming into a great stroke unit die after a stroke. But promisingly, at least, only a small study, only 34 patients, it looks as though the IL-1 blocker tended to cause an improvement, which is promising. We're now undertaking a larger study in subarachnoid hemorrhage, actually, because it can be easier because they tend to come into hospital more quickly. We need to be sure we've got exactly the right dose, and then, of course, we need to undertake a large clinical study. And large might be a few thousand patients, and it might cost tens of millions of pounds. And here is an interesting feature, because the patent for making the IL-1 blocker is held by an American company. The patent for using it in stroke is held by the University of Manchester. And so I've spent as much time on legal matters as I have probably on experimental matters. But just to highlight, I said at the beginning, there are a lot of similarities between stroke and other diseases, and I'm not going to go into the others, but just to say that we now know that there is increased levels of IL-1 in the brains of patients who've had an injury after epilepsy and infections, tumours, Alzheimer's, Parkinson's, etc., etc. And we also know from imaging, for example, that there's evidence of inflammation in all of these conditions. So it could be that blocking IL-1, or indeed blocking other inflammatory agents, might be of wider benefit in many other conditions. And that's something that we're studying on the sidelines. So just briefly in the last few minutes, let me say that I talk about these things. These are the people who do the experiments. So people in the lab have very varied backgrounds. The dog's my pet, by the way. He's not an experimental animal. He came to visit us. But James is a neurosurgeon. Pete trained in biology. They trained in maths first, actually. Stuart's a senior lecturer. Emmanuel's a lecturer. A lot of them seem to be in the pub. But they come from 14 countries, I think we have in the lab. And then, of course, there's a group of doctors, both neurologists, neurosurgeons, and research nurses at Hope Hospital doing these studies.